Good morning, Dr. Sikri.
Good morning.
Good morning, everyone, and thank you for attending our PNT committee. We are at quorum. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. PNT committee members, please reserve your question until the end of the presentation or ask in the Google Meet chat. Public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the P&T committee, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And with that, I will leave it to you, Dr. Sikri.
Thank you. The first item on our agenda is to review and approve the minutes from Thursday, November 19th, 2025. Has everyone had a chance to review those minutes?
I can make a motion to approve.
I'll go ahead and second. All in favor?
Aye.
Aye.
Any opposed or abstentions? Hearing none, the minutes have been approved. And we'll go to the second item, housekeeping. Noon, I'll let you go ahead and do that.
Yes. So we have 2 new P&T committee members, and I would like to introduce Dr. VJ to the board. If you would like a few minutes to, Dr. Kill, if you would like to introduce yourself to the committee. Dr. Kill, if you are speaking, we can't hear you. I think we can maybe circle back with Dr. VJ Kell in a second. We also has Tad Jolie. He's also a new committee member as well. Tad, would you like to take a few minutes to introduce yourself to the committee?
Sure. My name is Tad Jolly. I own Jolly's Pharmacy, Redwood in West Jordan. I've been a pharmacist for 36 years, and all of that time has been spent in retail, so I have a vast knowledge of pharmacy and running my own business, and I'm glad to be part of this committee.
Thank you, Dr. Jolie. And we also have with us, starting from today, will be Spencer Miller. He is a pharmacy technician on the pharmacy team. He will be the one who will be taking note and the minute for the committee. Spencer, you want to just say hi to everyone?
Yeah, hello. I'm part of Medicaid. I've been here for a little over 6 years now. If you've been in this meeting long enough, you may remember me doing it before. But yeah, I'll just be helping with the minutes.
Thank you, Spencer. Dr. Kell, let me know if you're able to do some introduction to the committee. He might experience some difficulty technological. I think we can circling back in a second when he be able to say something to the committee. The second item that we have for the housekeeping is the hybrid PDO Go Live update. So the Senate Bill 3 New Fiscal Year Supplemental Appropriation Act of 2025 General Legislative Section were passed last year to require an establishment of the hybrid unified PDO for certain drug class to be aligned between the Utah Fee-for-Service and ACO. Some of the classes, including hepatitis C, antiviral for HIV, anti-diabetic, glucose monitoring, continuous glucose monitoring is as immunomodulator. The project for the hybrid unified PDL has been worked on for several months during 2025 and has been in effect since January 1st of 2026. Both the state and the plan are continuing to monitoring the process and continue to coordinate our effort to iron out any gaps, and we can report back to the committee later on. But so far, it has been going on well. That's all the housekeeping updated I have.
Luis, do you have the DUR board update from this month?
Yes. So the DUR board was able to meet each month. So in September, we met to review new prioritization criteria. And then in October, we met to discuss the topic of concomitant use of oral buprenorphine containing products with full agonist opioids and the use of oral buprenorphine containing products other than Belbuca for pain. In November, we met to review new prioritizations, especially related to the hybrid PDL, like the immunomodulators. In December, we discussed new PAs as well. In January, we met to discuss the combination Botox and CGRP antagonists for chronic migraine. And then this month, we met to discuss new prioritization criteria. And in March, we'll be discussing the GLP-1 antagonist for use in weight management. Thank you.
Thank you. The next item on our agenda is public comment from Eli Lilly, Dr. I'm probably going to mispronounce your name, Lubelzik.
Yes, good morning. Can you hear me?
Yes.
Okay, wonderful. So good morning. My name is Elizabeth Lubelzik, and I'll be providing testimony on tirzepatide, brand name Zepbound. Zepbound is a once-weekly injectable dual GIP and GLP-1 receptor agonist indicated in combination with diet and physical activity for chronic weight management in adults with obesity or overweight with at least one weight-related comorbidity, and for the treatment of moderate to severe obstructive sleep apnea in adults with obesity. Clinical efficacy for chronic weight management was demonstrated across the SURMOUNT Phase 3 program, where tirzepatide produced statistically significant and clinically meaningful weight reduction versus placebo. At higher maintenance doses, mean weight loss approached 20 to 23% at 72 weeks, with consistent effects across key patient subgroups, including those with common cardiometabolic comorbidities. In SURMOUNT-5, a head-to-head Phase 3b study, tirzepatide demonstrated superiority to injectable semaglutide in both percent and absolute body weight reduction at 72 weeks. In SURMOUNT-OSA, tirzepatide met all primary and key secondary endpoints in patients with moderate to severe OSA and obesity. In a real-world study using a commercial claims database, 73.8% of patients using tirzepatide were persistent at 6 months. Persistent users experienced a mean weight loss of 12.9%, which is consistent with that seen in SURMOUNT-1 at 24 weeks, even though real-world dose escalation was slower than in clinical trials. For all safety information, including a boxed warning, please refer to the prescribing information. The safety profile of tirzepatide was consistent with the GLP-1 class, with predominantly gastrointestinal adverse effects that typically occurred early in treatment with dose escalation. In summary, tirzepatide provides robust and durable weight loss, supporting its consideration as therapeutic option for patients with obesity and obesity-related complications. Thank you for the opportunity to share this information today, and I'd be happy to take any questions.
Thank you.
Thank you.
Noon, do we have any other public comment?
That is the only one we have today.
Okay, thank you. So we will move on to item number 5, review of the GLP-1 receptor agonists approved for weight management. Dr. Gonzalez?
There we go. I didn't realize my mic was off. Okay. Do I have those slides showing for you there?
Yes.
Let's see here. Okay. So today we will be reviewing the glucagon-like peptide 1 receptor agonists, abbreviated GLP-1 RAs, that are approved for weight management. This includes liraglutide as the Saxenda formulation or its generic equivalent, semaglutide as the Wegovy formulations, and tirzepatide as the Zepbound formulation. GLP-1 RA approvals for weight management followed initial approvals of GLP-1 RAs for the treatment of type 2 diabetes, with the earliest approved agent in this drug class occurring in 2005. The weight management formulations have been available as subcutaneous injections since their initial approval, and most recently an oral formulation of semaglutide has been approved. GLP-1 RAs act in the central nervous system to enhance satiety and reduce hunger. They also have glycemic regulating effects and slow gastric emptying. In addition to GLP-1 RA action, tirzepatide is also an agonist at the glucose-dependent insulinotropic polypeptide, or GIP, receptor, which is thought to also contribute to regulation of appetite. The reviewed products are approved for weight reduction and maintenance in adults with obesity or with overweight plus at least one obesity-related condition. Liraglutide and subcutaneous semaglutide are also approved for adolescents with obesity. Semaglutide as Wegovy and tirzepatide as Zepbound have additional approved indications for specific obesity-related conditions in adults. Semaglutide is approved for MACE risk reduction and for metabolic dysfunction-associated steatohepatitis, or MASH. Tirzepatide is approved for the treatment of moderate to severe obstructive sleep apnea, OSA, in adults. For each indication, these medications are approved as adjunctive therapy to lifestyle modification, including increased physical activity and a reduced calorie diet, and they are established for chronic therapy. The labeled indications for the reviewed agents no longer include specific BMI criteria to define obesity or overweight, as was used in some earlier labels. This change suggests the FDA is de-emphasizing BMI as a singular component for diagnosing or classifying obesity. This slide lists the labeled recommended maintenance doses for the reviewed weight management products. To mitigate gastrointestinal side effects, doses are generally started low and gradually titrated up to the recommended target dose. The subcutaneous dosage forms of semaglutide and tirzepatide are long-acting products that facilitate a once-weekly dosing interval, whereas liraglutide and the oral form of semaglutide must be administered daily. As there are several approved formulations of these active ingredients, it is important to note the differences in doses between the weight management and the glycemic management formulations. Notably, the liraglutide and semaglutide formulations for diabetes, shown on the right, have a lower dose range than the recommended maintenance dose range of the weight management formulations, shown on the left. The recommended maintenance dose range for tirzepatide is the same across each indication. Before I describe the guideline recommended place in therapy of the reviewed agents, I want to first provide some important disease background information. Obesity affects approximately 40% of US adults and 21% of the US pediatric population. Obesity is a long-term health condition of excess adiposity that increases risk and progression of obesity-related complications and diseases, abbreviated ORCDs, including type 2 diabetes, OSA, and fatty liver disease, among many others. ORCDs stem from the prothrombotic, pro-inflammatory, diabetogenic, and biomechanical effects of excess adiposity. Adipose tissue excretes hormones and chemical messengers, some of which that contribute to the development of ORCDs. Excess adiposity that increases the risk of or that has progressed to ORCDs is referred to as obesity and is conveyed by the umbrella term adiposity-based chronic disease coined by the American Academy of Clinical Endocrinology, or AACE. The term adiposity-based chronic disease, abbreviated ABCD, highlights that the clinical spectrum of excess adiposity extends beyond BMI thresholds and encompasses the early development and the progression of related chronic diseases. Experts are shifting away from using BMI independently to classify obesity. The diagnosis of obesity and ABCD focuses on verifying excess adiposity and its distribution and assessing the health impact of excess adiposity on the individual. As reflected in the table, ABCD encompasses both preclinical obesity and clinical obesity. Clinical obesity refers to excess adiposity plus the presence of obesity-related complications, whereas preclinical obesity refers to excess adiposity that increases the risk of developing clinical obesity and ORCDs, but with no overt complications present. The staging of ABCD as stage 2 or 3 is based on the provider's clinical judgment regarding the clinical severity of the patient's respective ORCDs. While I mentioned a few example ORCDs previously, the slide gives a fuller view of associated diseases and complications of obesity or ABCD. Some of the reviewed products have shown positive outcomes in completed phase 3 trials for specific ORCDs, including the prevention of type 2 diabetes and for the improvement of osteoarthritis, knee pain, or heart failure related symptoms. For many years, key medical organizations have considered obesity a chronic condition that requires long-term treatment. Goals of therapy for ABCD are to prevent, slow the progression of, or to improve ORCDs by weight reduction and maintenance. Weight loss of 5% or more from baseline is generally considered a meaningful improvement because it is correlated with clinically significant improvements in cardiometabolic parameters or improvements in specific ORCDs. Higher weight loss targets may be pursued for certain disease-modifying effects. For example, a reduction of weight by at least 7% is associated with improvements in OSA and prevention of type 2 diabetes in patients with prediabetes. Guidelines recommend individualizing medication selection according to the patient's clinical profile, considering their comorbidities, patient preferences, and access to therapy, while using a shared decision-making approach. Regardless of the agent, pharmacotherapy is recommended as an adjunct to lifestyle modification. Because the reviewed therapies can substantially reduce food intake, experts emphasize providing nutritional consultation and intervention if needed to prevent nutritional deficiencies, and that patients should incorporate resistance exercise to maintain and promote muscle mass while on GLP-1 therapy. Agents approved for chronic weight management are listed in this table. Those approved prior to 2015 will be referred to as first-generation agents, which includes liraglutide. Newer agents are referred to as second-generation agents, including semaglutide and tirzepatide. Generally, in the phase 3 pivotal trials, first-generation agents demonstrated mean body weight reductions of 10% or less, whereas the second-generation agents typically averaged mean body weight reductions of greater than 15%. According to the 2025 AAC consensus update, anti-obesity pharmacotherapy can be considered for adults at all stages of ABCD. Medication preferences are stratified according to the stage of ABCD and to patient-specific ORCDs, with considerations for step therapy to address affordability. Second-generation agents, if available, are strongly preferred over first-generation agents for first-line therapy in those with stage 3 ABCD, and if resources permit for the treatment of most ORCDs in general. However, because costs may be prohibitive for second-generation agents, the AAC highlights that first-generation agents can be effective for weight management in many people. In the presence of affordability limitations, first-generation agents are suggested for first-line treatment in people with stage 1 or 2 ABCD. And after observing response, therapy could be intensified if needed to achieve clinical goals. The 2025 V8 guideline recommends long-term pharmacotherapy for patients with a BMI of 30 or greater, or at least 27 plus an obesity-associated condition. Similar to the AAC consensus statement, this guideline also strongly recommends using semaglutide or tirzepatide to achieve weight loss goals in conjunction with lifestyle therapy. A weaker recommendation was made for liraglutide and other first-generation options. For patients with type 2 diabetes and overweight or obesity, the American Diabetes Association strongly recommends considering obesity pharmacotherapy. In a 2023 guideline, the American Academy of Pediatrics recommended offering weight management pharmacotherapy adjunctive to behavioral and lifestyle treatment to adolescents 12 years and older with obesity. 2 head-to-head randomized controlled trials have compared the reviewed agents administered at their FDA-approved maintenance doses for weight loss. Step 8 compared sub-Q semaglutide to liraglutide, and SURMOUNT-5 compared sub-Q semaglutide to tirzepatide. Both studies were open label with respect to active arm comparisons and included adults without diabetes but with obesity or overweight, plus at least one weight-related comorbidity. All arms in each study were provided counseling to encourage and guide lifestyle modifications. Semaglutide significantly outperformed liraglutide at week 68 for percentage change in body weight from baseline. Semaglutide treatment exhibited mean reductions of 15.8% or 17.1%, depending on the analysis estimate type, while liraglutide exhibited reductions of about 6 to 7%. Significantly higher proportions of patients randomized to semaglutide achieve the weight reduction thresholds of at least 10%, 15%, or 20% compared to liraglutide. Significantly greater improvements with semaglutide were also demonstrated for other cardiometabolic parameters, such as waist circumference, total cholesterol, VLDL, A1C, and C-reactive protein. Adverse events of any type were common in each arm, including in the placebo arm. GI events were the most common type of event across the active arms, but most were mild to moderate severity. Treatment discontinuation due to GI events occurred in numerically more patients receiving liraglutide than semaglutide. In SURMOUNT-5, tirzepatide significantly outperformed semaglutide for the primary endpoint of percentage change in body weight from baseline to week 72. Tirzepatide reduced body weight by 20.2% or 21.6%, depending on the estimate type, compared to reductions of about 14 to 15% with semaglutide. Significantly higher proportions of tirzepatide-treated patients achieved weight reduction thresholds of at least 10, 15, and 20% compared to semaglutide. Tirzepatide treatment also yielded significantly greater improvements than semaglutide for other cardiometabolic parameters, including waist circumference, VLDL, A1C, and blood pressure. Overall incidences of adverse events of any type were similar in each arm. GI events were the most common event type, but most were mild to moderate in severity and mainly occurred during the dose escalation phase. Treatment discontinuation due to GI events occurred in numerically more patients receiving semaglutide than tirzepatide. Regarding safety information, many of the labeled warnings are the same across the reviewed GLP-1 RAs. Contraindications to each agent include a personal or family history, of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. There is also an associated black box warning regarding the risk of thyroid tumors, which were observed in animal models. Severe GI events have occurred with GLP-1 RAs. GI events predispose patients to dehydration and acute kidney injury, which are also labeled warnings for each product. However, gradual titration schedules can help minimize GI effects. Additional key warnings include observed events of acute pancreatitis and suicidal ideation. However, a causal effect remains unclear for those. GLP-1 RAs are associated with acute gallbladder events. Guideline authors describe that this adverse event is associated with rapid weight loss in general and is a risk with any effective weight loss therapy. Use of the reviewed agents for weight loss is not recommended during pregnancy due to the potential for fetal harm. Semaglutide and liraglutide also have a warning for complications of diabetic retinopathy, which is an effect associated with rapid glycemic improvement in general. The reviewed GLP-1 formulations approved for weight management offer a moderate to high magnitude of effect for weight reduction and maintenance and are established for use as ongoing therapy. Because ABCD or obesity is a chronic condition, guidelines support long-term pharmacotherapy as a treatment option adjunctive to lifestyle modification for indicated patients to lessen ORCD risk and burden. To help support these goals, you may consider having at least one GLP-RA formulation approved for weight management with a preferred designation on the PDL, and for patients to potentially have access to non-preferred GLP-1 RA options on a case-by-case basis if not meeting their individualized clinical goals with the resultant PDL preferred agent or to satisfy other clinical considerations. To accommodate financial limitations, the AAC highlights that step therapy through a first-generation agent before trial of a second-generation agent can be considered for those with less ORCD burden, while prioritizing first-line use of second-generation agents to patients with greater disease burden, such as stage 3 ABCD. Depending on the resultant PDL preferred option, the prior authorization pathway could be designed to accommodate guideline recommended first-line therapy for stage 3 disease to more promptly and reliably achieve weight goals. Based on outcomes in pivotal clinical trials, most patients with weight loss goals of greater than 10% or greater than 15% are expected to require treatment with a second-generation agent, such as semaglutide or tirzepatide, to achieve such magnitude of effect. For example, the majority of liraglutide-treated patients in the SCALE phase 3 trial were unable to achieve 10% or more weight loss by week 56, whereas the majority of semaglutide-treated or tirzepatide-treated patients were able to achieve at least a 10% weight loss in the phase 3 pivotal trials over 68 or 72 weeks. Overall, weight goals and clinical goals are to be individualized, and response to these therapies on an individual level is highly variable across treatments. Thank you so much for your attention through that. Please let me know if you have any questions.
Well, thank you for a very concise and informative summary. I'll open up the meeting now for discussion regarding the GLP-1 receptor agonists for weight management.
Valerie, during your review of the pivotal trials, was there any discussion about discontinuation of therapy secondary to needle phobia?
For this review, I don't go through like each of the pivotal trials on their own. I mainly went through, those head-to-head trials. I didn't see them do, like in the main report, I didn't see them mention any survey about, patient reported needle phobia, but I sense that may be the case in other, just in general, when I review drug classes where you have an injectable devices, I haven't seen anything specifically with the GLP-1 RAs, but just anecdotally, I've kind of heard that some patients get tired of the, of using the injection and might be interested in an oral, but the orals have their,
Yeah.
those must be taken daily. So I don't know that, there's kind of a give and take with each form, but yeah, mainly I just hear anecdotally about that.
No, that's really helpful. I'm just using the crystal ball approach, trying to get an idea of the market demand for an oral alternative, right? Depending on the papers you read with regards to some level of needle phobia, it can be pretty high, as high as 30 to 40%.
Okay.
I'm just thinking about the popularity of these agents, right? And the fact that some of these patients may not be utilizing them secondary to needle phobia and then just waiting for an entrant to hit the marketplace. So it'll be interesting to see how the market may shift secondary to the oral options being available. And I guess and based on just the preliminary information I have on the oral semaglutide in type 2 diabetic management, and we haven't really seen much market shift or utilization of that particular agent. Secondary to, like you said, it's pretty onerous for the patient. It'll be interesting to see how the oral Wegovy now plays. And so I have another question, Valerie. You mentioned that there's side effects we would anticipate: injection site reactions, GI side effects. There's a lot of data out there about kind of these sentinel signals with regards to some more unusual side effects associated with these particular drugs. Based on the work you did you see any side effects secondary to unusual skin sensations, tremor, through your review?
No, but I don't pull like I said, I only do deep dive package inserts and those head-to-head trials, and then I mostly was looking at efficacy out of the pivotal trials. So I haven't looked at any other thing that might have been reported since then that may come up in like observational evidence.
Yeah, observational. I've had a particular provider say that in the clinic they've noticed tremor, but it's not something I was able to validate based on the data that's available specific to tremor. But there is some notes with regards to unusual skin sensations, tingling and whatnot. It was one of the side effects reported in the higher dose they used in the oral Wegovy, the 50 milligram dose, and ultimately why they settled on the 25 milligram dose.
Okay.
But it just hadn't been something I had seen in the injectable products.
Yeah, will be interesting. There is that a phase 3 trial that was completed with Wegovy subcutaneous at a high dose at 7.2 milligrams weekly.
Really?
For type 2 diabetes. So I haven't looked at that one yet, but that one might be interesting to look at, what other side effects.
At these higher dose
thresholds. Yeah, the higher doses. I I cited that one somewhere in the, but I could pull that study for you.
If it's cited and we have access to the deck, we should
Yeah.
be fine. So thank you. It's a good jumping off point.
Mm-hmm.
Is there much data on, like, once you reach your goal, how long you stay on the medication, or for X amount of weeks, or is it sort of indefinite just based on the length of studies at this time?
Well, that's actually the kind of the DUR topic that we're looking at next week. But yeah, it's very slim as far as what to do once you reach your goal. I mean, so far it seems like most patients are going to start regaining the weight on average, but some studies, once you look at what happens in each patient, there are some patients that are able to maintain their weight once they discontinue it. So it's not necessarily a one size fits all thing, and it's very individualized, but on average, the weight does gradually come back, is what it seems. And so clinicians, when I listen to speakers speak, they're thinking of this disease as how you would hypertension, diabetes, where you're treating long term and you need something for maintenance. Generally speaking, you might have anyway. So. But our upcoming DUR report will consolidate, what we found or what we didn't find across guidelines. And
I'm hoping you found something. I
reviews.
think the market's hoping you found something. That there's
Yeah, I
something,
mean-
there's some potential.
I
Right
really
now,
hear
yeah.
experts push, the lifestyle modification piece. And if patients can do that and really incorporate that and make that a habit, it seems like maybe those are the ones that can sustain the weight loss long term once you discontinue it.
Any motions with regards to GLP-1 receptor agonists in terms of recommendations?
I can make a motion to establish I want to give a background a little bit. Is right now, the funding for anti-obesity for the state is supposed to be ended in June 31st of 2026. So the motion can be made with the conditions that the funding will be extended beyond the coverage expiration day of June 31st of 2026. So I can make a motion to have at least one GLP-1 RA formulations approved for weight management could be considered for the PDL.
And as Noon stated, it's contingent on the appropriation. continuing after June 30th,
Mhm.
2026.
And I would second that motion. Again, contingent on continued state funding.
Yeah.
All in favor?
Aye.
Aye.
Any opposed? Hearing none, the motion carries. And we'll look forward to the DR board next month, hopefully being able to address all of the nuances in terms of access for pediatrics, the oral formulation, and the first versus second generation distinction between the medications. So our next meeting is Thursday, May 21st, 2026, and we will be reviewing opioid reversal medications. Do I have a motion to adjourn?
Just real quick, I just wanted to sneak it. Looking at the claims data, do we want like a grandfathered clause there? Because I feel like that came up in the review as far as like not switching if an agent they're on is not selected for the PDL.
Certainly.
Yeah.
And I would second that. I'm sorry.
Yeah, I can phrase that better.
Yes.
A grandfather clause essentially to continue a previously established regimen within the last, I'll say 90 days. Feels like a good time frame for this.
Yes, with a noon, is that okay with a 90-day look back for therapy? If someone is currently on a GLP-1 agonist that does not become the one that is on the formulary, can they continue the one they're currently taking?
I
So are we
think
thinking about this in a scenario where we get additional appropriations associated with this weight loss pilot?
Okay, again, with the,
Well, because I kind of think of it just from the like efficacy and safety standpoint. That's where I kind of look at our committee's role is like, I don't know that I would say it's like contingent on the efficacy and safety aren't necessarily contingent on it. I agree, someone has to make that decision, but I'm not sure that's us. It certainly affects us, but
so. The grandfathering clause also contingency on, as Tom said, it contingency on the appropriation funding when we establish the class. So the people who get the medication will be affected by the refer and non-refer of the classes when it established. Is that what you meant, Cole?
well, yeah, I was just kind of thinking like we would continue, and obviously if there is a change, and maybe I may not be understanding the effects there, whether the funding continues or not. But I sort of look at our role as like the safety and efficacy of it. And I'm not used to putting a contingency for funding on our motions, but certainly understand the uniqueness of this situation.
And Cole, we do have a continuation of care therapy in addition to an exception process. And if we made the decision based on whatever future state looks like, they would have the ability to potentially be grandfathered on an agent.
Fair, and that's been my experience too. I just sometimes call that out, especially in Valerie's review, where she noted that like finding that right agent is an inexact science. It sounded like is how I describe it.
so would you like to restate your motion?
Sure. For patients on established GLP-1 RA therapy with a look back of 90 days, that they could continue that agent if used in the last 90 days, if that agent is not included on the PDL.
I would second that motion. All in favor?
Aye.
Any opposed or abstention? Thank you, Cole. This used to be my role.
I was just thinking that.
Okay. Any other discussion? Otherwise,
Sudan, this is Vijay KL. My first meeting, first few minutes, I was having little trouble joining in. I couldn't hear anybody, or like I couldn't talk. So I rejoined from another computer. If there is anything that I have been missed, since this was my first meeting, so nothing more than that.
well, welcome to the P&T committee.
Thank
Thank you for your service. Do I have a motion to adjourn?
Motion.
Second?
I'll second.
Okay, all in favor? Aye.
Aye.
All right, so we will meet again in May and be looking at the opioid reversal medications. All of you drive safely out there, given the amount of snow we just had, and take care. Thank you.